He has obliged us many times with different topics, which have been extremely helpful. The ADS has these two, Back to School and Healthcare Forum, as part of a much broader and much larger spectrum of the community service. These two forums are not meant for any medical advice, nor they are consultations. And I suggest in the question answer sessions as well, please do not ask personal questions, your personal condition, etc., because that becomes a part of consultation. The speaker does have a right not to answer the questions. We seek highest quality speakers who are recognized in their field, and we also look for the most common topics, most common conditions, and most important conditions which are prevalent in our community. So with that, I would like to reintroduce Dr. Dhiren Nanavati. He is a renowned orthopedic surgeon, had a very illustrated career both in Marion, Ohio, and here in Stockton, and has been very kind to ADS members that he frequently returns and gives us knowledge and his wisdom. So with no further ado, I present to you with great honor and pleasure, Dr. Nanavati. Dhiren bhai, microphone is yours.
Thank you. Thank you very much, Deepak bhai, for a very kind introduction. Today we are going to talk about arthritis of the knee. The reason why today I have selected this topic is because it is a very common condition in population in general, and particularly in people from India. A lot of people have questions about arthritis, and hopefully I will be able to share with you some information regarding the condition and how to manage it. I would like to disclose here that I have borrowed slides from several sources so that I can make the presentation more enjoyable and understandable. So we'll talk about arthritis of the knee. So before we go into arthritis of the knee, we need to know what a normal knee looks like. So this is a schematic presentation of a knee joint. This is the thigh bone called femur. This is the leg bone called tibia. They make the joint. The end of the bone is covered with very nice, shiny cartilage or joint surface. You can see it on tibia, and here you can see it, a femur and on the tibia. The two bones are connected with each other by ligaments. So these are the two outside ligaments, and these are two inside ligaments called cruciate ligaments. These are called collateral ligaments. Between the two bones, nature has put a cushion, which is called meniscus. Quite often, lay people, when they say, I have a torn cartilage, what they really mean is they have torn meniscus. So meniscus, there is one on the inside, one on the outside. And in front of the knee, there is this kneecap or patella. The main quad muscle is attached here to the patella, and then from patella, a tendon goes to the leg. So when the muscle on the top pulls the kneecap pulls on the tendon, and then the tendon pulls on the leg. So that's how the knee functions. So I would like to draw your attention to the fact that look at the joint surface. It is nice, shiny, and very smooth. So that is normal looking cartilage. This is what happens to it when you get arthritis. So this is again the femur bone. You can see that the articular cartilage has become rough. At many places, the cartilage is missing. That exposes the bone. Cartilage does not have any nerves, so it does not have any sensation. That's why in normal knee, you don't feel any pain. But once you have lost the cartilage and the bone is exposed, bone does have nerves. And that's why you feel pain once you get arthritis. You can see that the menisci have become worn out. They are not nice and smooth anymore. the joint is trying to be bone on bone, and nature tries to heal the bone but fails to do so, and the byproduct is what is called bone spur or osteophytes. So this is what an arthritis joint looks like. What is arthritis? As it is aging of the joint surface. It undergoes wear and tear, it becomes rough and the bone is exposed, spurs form around the edges, the inner lining of the joint called synovium gets swollen, and there is an excessive amount of fluid that forms in the knee, and that's why the knee looks so swollen and is painful. And ultimately, the ligaments deteriorate, leading to instability of the joints. A lot of people feel that an arthritic joint is unstable, and that is because the joint has become so rough, the muscles are weak, there's a lot of fluid in the joint, and there's a lot of pain. This is a schematic presentation of a normal cartilage. The white structures are called cells. They are cartilage cells. Now this is trying to describe what the cartilage looks like under microscope. So cells, and then there are nuclei. They are like the nerve centers of the cells. And all these cells, like tiles on our floors, are embedded in this yellow material, which is called extracellular matrix, or let's say grouting. And all the lines that you see, they are collagen fibers. So the cells are like tiles sitting inside the grouting made by this yellow stuff, and the supporting structures are these what are called collagen fibers. We don't know why arthritis occurs, but we do know that something happens to this yellow substance. Its chemical nature changes, so these fibers break down. When they break down, they can't support the cells. Cells start hitting each other, and they deteriorate because of irregular pattern of the substance now, and that leads to arthritis. So arthritis is common in many joints. The joints which most commonly get affected are the cervical spine or the neck, the lumbar spine, the two sacroiliac joints, which are like connection between the spine and the pelvic bone, the hips, the knees, and the joints of the fingers. These are the joints which most commonly get arthritic changes. Now, arthritis is of two types. One is called primary osteoarthritis, which is arthritis of aging, and secondary osteoarthritis, which is because of certain things that have happened during your lifetime to the knee, and then they lead to arthritis. So, primary osteoarthritis, which is, we don't know how it occurs, and it occurs because of age. It is more common than secondary arthritis. Like I said, we don't know exactly why it happens. It is common in older people where there was nothing wrong with the knee before, and now the knee starts becoming painful and swollen. And it is due to wear and tear occurring with old age, mainly in the weight-bearing joints. While secondary osteoarthritis can occur if you had injury, infection, rheumatoid arthritis, congenital deformity, or any other deformity where the leg had, a break, or thigh bone had a break, and now the leg is deformed. It can lead to arthritis, excessive weight, and hyperthyroidism. There is one more condition that can be described here, which is called psoriatic arthritis. People get psoriasis, which is a skin disease, and it leads to arthritis as well. So what are the risk factors? There are certain factors that you just cannot change. So what is that? So family history or heredity. So there are some families in which the arthritis is more frequent and more severe. Age, as we get older, that is, you can't control changes of age, that leads to arthritis. And somehow females are more prone to get arthritis compared to males, and that has something to do with the fact that they have wider pelvis, So the angle between the femur and the tibia is much more compared to males, and that somehow leads to increased weight bearing on one side or the other of the knee, leading to arthritis. What are the factors that you can control? So you can watch your weight, no smoking, good diet with proteins, vitamins, and low in fats, low impact exercises. This is something that you can control. If you are able to do jogging or a lot of heavy weightlifting, you are more prone to get arthritis. Calcium and vitamin D help by maintaining the strength of the underlying bone, maintaining strength in the muscles by doing some regular exercises, and seeking professional help if the knee becomes painful. So these are the factors that you can control. So who gets arthritis? The people above age of 45, females more commonly, and especially after menopause because the bones are somewhat weaker. People with excessive weight, obesity, uh, especially if your BMI is 35 or 40, you are very prone to get severe arthritis. Previous knee injury, a malalignment of the legs, squatting and sitting cross-legged is known to cause increased pressure over the medial aspect of the or inner aspect of the knee. High impact activities like jogging on hard surface and jumping sports, weak muscles, for example, somebody with poliomyelitis or nerve damage can get arthritis more commonly in the knee because the knee is not under good muscular control, and osteoporosis. The osteoarthritis of the knee from epidemiological viewpoint is one of the most disabling conditions in adults. It leads to decreased work productivity, loss of time from work. A person has to take sick days off very frequently, and it has a very high medical expense for treatment. And not only medications, but braces, steroid injections, gel injections, and expensive surgical procedures. And somehow in our population, with a habit of sitting cross-legged and squatting, people from India seem to have more arthritis. Uh, if you are 60 or 65 years of age or older, you have almost an 11% chance that you have very painful osteoarthritis of the knee. How does the knee work? So the leg bone is a flat bone and the femur bone is a rounded bone. So the leg bone kind of glides on the thigh bone like a hinge. Now, the joint surface of the cartilage that I showed you in the first slide is like a sponge. And when you bear weight on the leg, a little bit of fluid is squeezed out into the joint from the cartilage. So cartilage is like a sponge, and the fluid seeps out into the joint. And when you take the weight off the leg, the fluid goes back into the cartilage. The fluid that is put in the joint provides lubrication, and it also provides nutrition to the joint. 4 ligaments provide stability, and menisci provide cushion between the 2 bones. So this is the comparison again of normal and abnormal joint. So on this side is the normal joint, nice smooth white cartilage, nice space, strong capsule, strong ligaments, good healthy bone. In arthritis, there are cyst formations, there are spurs, the joint space gets narrow, inner lining is all inflamed, the capsule has become very thick, too much fluid is formed in the joint, and that leads to pain. This is a finger joint, and this is a microscopic picture of arthritic joint. So a spur has formed, the cartilage is all worn out from here. Here you can see some cartilage. It is trying to be bone on bone. And the bone underneath starts forming a cyst. So this is microscopic appearance of arthritis. Now there is a definite relationship between weight and arthritis. The heavier you are, the more chance you have that you have painful arthritis. So what is pressure on a joint? That is measured in pound per square inch. Now, if an average person weighs 150 pounds, when a person lies down, there is no weight and therefore no pressure on the joint. When you sit up, there is minimal amount of weight that you put on it, and therefore there is some pressure. When you stand, you will put 1 times body weight per square inch. So a 150-pound person would put 150 pounds per square inch pressure merely standing. Now you can imagine that if it was a 200-pound person or 250-pound person, that much more pressure you are putting on 1 square inch of joint. When you walk, that goes up to 4 to 5 pounds body weight per square inch. Why? Because of muscle forces, because they bring the two bones together nice and tight. When you run, that becomes 6 to 7 times body weight per square inch pressure. So can you imagine if you're running, you're putting, let's say 6 times, you are putting 900 pounds per square inch pressure on each square inch of the joint surface. And jumping and squatting put about 8 to 10 times body weight per square inch. So if you were to do a lot of weightlifting and you are already heavy, you can imagine that you are adding that much weight to your own weight. So this is the relationship between arthritis and weight. And conversely, if you are, say, 200 pounds and you reduce your weight to 150, your joint will feel much better because you have really reduced a lot of force being applied to the knee when you do this activity, standing, walking, and running. Okay, what does the knee look like on X-ray when you have arthritis? So this is the normal knee. This space is nice and healthy. The bones look like what they are supposed to be, nice and round, good space, and good alignment of the leg. Once you start getting arthritis, the two bones start coming closer together. And this is what happens in osteoarthritis, where the inner joint gets a narrowing of the space, and that is arthritis. And in rheumatoid arthritis, quite often people get arthritis and bone on the outer part of the joint. But these both are arthritic joints. This is what a nice smooth cartilage looks like. But here the cartilage is all worn out. Here the cartilage is normal. And this is again normal joint and is trying to be bone on bone, and the bone looks whitish in color. That's a sign of arthritis. This is advanced stage of arthritis. So completely bone on bone, big cyst has formed here, large spurs. The leg bone should be in this direction. Instead, it is in this direction. So there's a lot of bowing, and behind the kneecap, there is no space left, and the kneecap rubs hard on the end of the femur bone. So this is a case of advanced arthritis of the knee. If we put a telescope in the knee, what is called arthroscopy, this is what a normal joint looks like, nice and smooth. Cartilage or meniscus is normal. This is the cartilage of the tibia and looks very nice, clean joint. Look here, no cartilage left, bone exposed, bone exposed. This meniscus seems to be torn there, and it is all degenerated, irregular looking, rough meniscus. So that's what an arthritic joint looks like when you put a telescope in the knee. So how does the arthritic patient present and how is the diagnosis made? So usually it is a slow onset and discomfort. It starts with a little ache and pain, and once you take rest, it gets a little bit better. Gradually, it gets worse. Then walking becomes difficult, standing becomes difficult. You cannot get sleep at night time, and you have to apply heat and take some medications and such. Initially, this pain is relieved by rest, but later on, it becomes continuous and it disturbs your sleep at night. And it can be diffuse, sharp and stabbing local pain on front or side of the knee. The types of pain, mechanical pain is when you put weight on it, when there is inflammation in the joint, there is constant dull pain because of swelling. Rest pain later on occurs in about half of the people, and at least 30% of the people get a lot of night pain with arthritis in the knee. So you can see this gentleman is severely bow-legged. That's because of severe arthritis. You can see that there is some redness, which is a sign of inflammation. And when the doctor examines you, he can feel that there's a lot of fluid in the joint. That is called effusion in the knee. So the diagnosis is made from pain, stiffness, swelling, crepitation. When you move the knee and you put your hand on front of it, you will feel some grinding sensation. That is called crepitation. And the leg may have some deformity and there is fluid in the joint. Sometimes to make diagnosis, they take a little bit of fluid and send it to the lab, and it shows it is clear yellow fluid. It has high viscosity, but the cell count should be less than 2,000. This is important. If this becomes 30 or 40,000, you have septic knee. So that's how they differentiate. And when you take an X-ray, like I showed, there are spurs or osteophytes, narrow joint space. The bone shows thickening, white color, and there are some cyst formations in the bone. That's how doctor makes the diagnosis of arthritis. Now, if you have swollen, painful knee, there are other conditions which can lead to the same thing, like rheumatoid arthritis, gout, crystal disease, septic joint, and there's a condition called polymyalgia rheumatica. So these are some of the conditions that look similar, and that's where your doctor helps you in making the diagnosis. So how do you treat arthritis? No known cure for osteoarthritis, unfortunately. Once you have arthritis, you have it. However, it is possible to improve the muscle function and reduce reduce the stiffness they should be, and make you more functional by symptomatically treating your knee. So it is amenable to therapy as well as exercises, but it is like diabetes. Once you have it, you have it. So what are the principles of treating osteoarthritis? So weight loss, very important. And especially if your BMI is 35 or above, you want to try to bring it down as much as you can. Exercise program will include physical therapy, quadricep strengthening, exercises to maintain motion. Low impact activities are very helpful, like swimming and bicycling are better than jogging. And you want to avoid jumping and running if you have arthritis in the knee. Sometimes people require some support in form of a cane or a walker. Sometimes it is helpful to use insoles. Soft gel-like insoles can be placed in the shoes, so they will act as a shock absorber and you don't transmit a lot of force to the knee. And there are braces called unloader braces, which are special braces to transfer weight from one side of the knee to the other, but they are controversial and quite often people are not comfortable using them. So we have to educate a person about the disease. We want to help him improve the function, control the pain, and if possible, try to reduce or decrease the progression in the disease. You can't cure it, but maybe you can slow it down. So I think we went over a lot of this: weight loss, physical therapy, exercises, muscle strengthening, patellar taping. And maybe Virtu will allude to this a little bit later, but you can, if there's a lot of pain in front of the kneecap can be taped so that you have less patellofemoral grinding, good footwear. Sometimes you can put a little wedge in the sole of the shoe so that the leg is a little bit better aligned. We can try either elastic or hinge braces and joint protection. What joint protection means is that a person with arthritis wants to schedule his or her day in such a way that you take break in between. Try not to do everything all at once, and take some rest in between, take a break and let the joint get some relief. You can put shoe inserts like this in the shoe to provide some more padding. Of course, diet is important. A protein diet, multivitamins, multimineral, green vegetables, and antioxidants. And they help you with some repair of the wear and tear of the cartilage. Medical management. So the most commonly used medication, substance is called glucosamine and chondroitin. It is available in various forms. Uh, it is known to give some pain relief, but there are no substances available yet that can restore your cartilage to normal. So you have to remember that glucosamine and chondroitin is not going to cure your knee, but it will make you feel a little bit better. Tylenol is mainstay of treatment for pain. You can also try, there are a lot of non-steroidal arthritis medications available, like diclofenac, indomethacin, emulsylide. There is a separate group of medication called COX-2. The commonest one is called celecoxib. This was sort of invented to remove the side effects of blood thinning as well as side effect on the stomach. There was another medication called Vioxx, which was in the same group, but Vioxx was then found to have cardiac side effects. So celecoxib is the most popular one in COX-2 inhibitor. It is supposed to be safer on the stomach, and it does not have any effect on the platelets, so it doesn't thin your blood. But it does have a little bit of cardiac side effects. So this is something that you want to discuss with your primary care about. Opioids, strong pain medication. Generally, we try to stay away from using this because they are habit forming and they also have potential side effects. Then the knee joint can have either steroid injection or gel injection. Steroid injections are known for a long time. They do buy you 2 to 3 months relief, but they do not cure your knee. It is essentially buying time. The gel injections are very popular. A lot of people ask about gel injections, but they are useful only in very, very early stage of arthritis because they require almost 70–80% of the normal cartilage present in your joint for it to work. In later stages, they don't help. You have to have 4 to 5 injections. They are very expensive. They are gel-like, so inserting a bigger needle is necessary. And again, sometimes they give you as much pain relief as cortisone injection. So these gel injections are given in well-selected patients. Everybody cannot be a candidate for this. Then, of course, you want to take calcium and vitamin D to maintain strength in your bone and antioxidants. So these are some of the medication like diacerin, cytokines. There is a hope that they would repair the cartilage, but that has not panned out. So quite often people spend a lot of money with a hope that I will get normal, but that has not happened. And there are also some enzyme inhibitors that can be tried. But again, these are all, I would say, at this point, controversial methods of treatment. We already talked about glucosamine. Now, some people try TENS unit. This is electrical stimulation of the soft tissues around the knee with a hope that the swelling will go down, the pain will go down, and other advantages that your muscles get a little bit more stronger with TENS electrical stimulation. Some people have tried acupressure and acupuncture. Again, acupressure is not bad because it is non-invasive, and you can learn that and try that. Acupuncture, a lot of people try that, they swear by it, but it is not known to cure arthritis. Then there are a lot of people who work on this, doing this: Tai Chi, yoga, swimming, biking, walking. And it is believed that non-steroidals give short-term benefits, and all these are complementary to that. So if you try some of these things, it may help you manage arthritis. Heat and cold. Different people have different tolerance. Some people like heat better, some people like cold better. So whatever suits you, you can use. If you're going to do some exercises, application of cold is quite helpful, especially before and after exercises. Cortisone injection. They are pretty safe. Uh, they are being given very commonly. A medication called Kenalog and Xylocaine are mixed and they are given together. They are expected to give about 2 to 3 months of relief at a time. As long as you stay beyond 3 months, you can have probably 4, 5, 6 injections before you decide that, well, I've tried this enough and I want to go and see what else can be done. It's important to use aseptic technique. If you put infection in the joint, then future knee replacement may not be as successful and in fact can get infected. So a doctor has to use a lot of precautions to make sure there is no infection. It is usually tolerated quite well, and it is known to give significant temporary short-term pain relief. These are the two methods of giving injection. Either it can be injected behind the kneecap or it can be injected in this joint space. This is a good method of giving injection in the knees, patient sitting up, and the two bones open up wide, and there's a large space through which you can go and inject medication. Stem cell injections. A lot of people have been asking about stem cells. Again, it is a developing science. There are certain conditions in medical field where stem cells are very important and have been very helpful. As far as the knee is concerned, it is still work in progress. Safety and efficacy of stem cell injection in the knee to cure arthritis is not proven. And there are a lot of unscrupulous, high-cost treatment plans available. I've heard of people spending $3,000, $4,000, $5,000 for 1 or 2 injections, and sometimes it leads to complications like infection. So it is still work in progress. Arthroscopy. So some people are advised to undergo arthroscopy for arthritis of the knee. It is helpful, again, in mild cases, and especially if you have a torn meniscus in the knee with some arthritis, and if your knee is locking up a lot, it is a helpful procedure. But once you have moderate to severe osteoarthritis, this procedure again has very limited value. So it is called joint clean out. They put a scope and trim deteriorating tissues, and they wash the joint out, and it does give some relief. But again, it does not cure arthritis. Now, when they put a scope in, sometimes they do drilling. So the bone that is exposed is, with a very fine drill, a few holes are made in that bone, and that causes some tissues to flow into the joint surface. And there is some evidence that cartilage is found to cover the areas, but that cartilage is not as good a quality as normal hyaline cartilage. It is fibrocartilage. So it again does buy you some time. There is a procedure called Oates procedure, where they take a piece of cartilage from the healthy part of your knee and transplant it in the worn out part of the knee. Again, it does have some benefits, but it has to be for one large area with remaining joint looking almost normal, and then it does help. Cadaver grafts, again, are work in progress. It has not been found to be very successful, and it is still in developmental stage. Now, you may have heard about people undergoing alignment surgery. So this is what is done in alignment. If the leg is bowed quite a bit, they remove a wedge of bone from the tibia, which is the leg bone, and then they essentially break the leg bone and bring it out to align it, and then they fix that break with a staple. Takes about 2 to 3 months to heal. And in days when knee replacement was not available, this was a very popular procedure. When I was a resident in India, this was a common procedure in orthopedics. It used to be called high tibial osteotomy. Nowadays, with invention of knee replacement, fewer and fewer surgeons know how to do this, and fewer patients undergo this operation at this point. Okay, so the next thing then is prosthetic joints. So if you are in a lot of pain, nothing is working, you are about 60 or 65, you're in good health, then you can consider having a joint replacement surgery. There are several types. Unicondylar means they replace just one compartment of the knee, or knee replacement. They are supposed to last for 10 to 15 years. Nowadays, they claim that they can last up to 20 years. Um, a few patients, this 10% number is probably a little bit high. About 1 to 2% of the people require redoing the joint during their lifetime. And this is usually a treatment of last resort. You want to try everything else first before considering replacement surgery. So this is what is called unicompartmental knee. You can see that the femoral condyle here is surfaced with a metal piece. The tibial part is also resurfaced with a metal piece, and in between there's a piece of plastic. So this is called medial compartment or unicondylar replacement. This procedure is done much less frequently compared to knee replacement because it is very difficult to find a joint where you have disease only in this compartment. For this procedure to be helpful, you have to have almost normal joint between the kneecap and the thigh bone, and almost normal outside of the joint, and just one joint is affected. Now that's pretty rare. Once you have arthritis, all three compartments of the knee start getting arthritis. So you replace one and the other two are arthritic, they remain painful. So you did not really get a good benefit out of this. So this procedure is done in well-selected younger people who had, say, for example, they had a fracture here, they have arthritis, rest of the joint looks good. Then you do what is called unicompartmental knee replacement. Since it is a smaller procedure, ligaments are spared, motion improves, recovery is quite fast, and it can last for about 10 years in 84% of people. So that is unicompartmental knee. This is what the total knee joint looks like. So now some people believe that in replacing the joint, a surgeon goes in and cuts off your leg bone there, thigh bone there, cuts off your leg bone there, and then they put a new joint in there. That is not so. They work with your own bones. So they just trim the arthritic portion, then they put a little bit of cement, and then they put a metal cap there. Similarly, they dig a little hole in the tibia, remove the arthritic bone, put a little cement, and put the tibial component in there. And this is the plastic insert between the two. There's a third component which is not shown here, and I'll show it to you on X-ray. Undersurface of the kneecap also has a little plastic button attached to it. So that is called total knee arthroplasty. So when you have pain during rest, that is the strongest indication. When there is arthritis in all three compartments, when there is severe pain, and when there is functional impairment, what that means is there are so many activities of daily life that you cannot do. You cannot stand much, you cannot walk much, cannot get good night's sleep. You have tried medications, you have tried cortisone injection, you are in good health, you are motivated, you have strong muscles, then this is a good procedure to undergo. Its main goal is to relieve your pain, but it does give you some functional gain. Anterior cruciate ligament is usually removed. You don't need that because the shape of the prosthesis is such that you don't need ACL. And this is an old slide. Right now, about 90 to 95% of people are expected to have their joint from between 15 to 20 years. So what are the needs? What is the requisite for total knee arthroplasty? Not everybody is a candidate for this. So preferably age above 60. Disabling arthritis may be exception. So say you have rheumatoid arthritis or avascular necrosis of bone or congenital deformity, then a surgeon can make an exception and do this for you under age of 60, or maybe trauma. BMI, which should be under 40, preferably under 35. Your hemoglobin A1C should be below 7. If your hemoglobin A1C is 8 or 9, meaning that your diabetes is not under good control, you have a very high risk of getting infection. At the time of procedure, you should not have urinary tract infection. You should not have any infected skin lesions on your body. You should not have any dental infection. You should not have any ear, nose, throat infection either. There should be no steroid injections in last 3 months before replacement. Otherwise, the incidence of infection goes up. No more than 20 degrees of flexion contracture. What that means is that some people have knee bent backwards severely and they cannot straighten it. If it is more than 20 degrees, then it is very difficult to replace your joint. And that's why it's a good idea not to let arthritic knee go too far before considering surgery if you are in too much pain. And one should have at least 80 to 90 degree bend of the knee. If your knee bends only 30 or 40 degrees, that's all you are going to get after the surgery. You'll have some pain relief, but you will not have much more motion. Why? Because your muscles and ligaments and tendons have scarred now from arthritis. So you can put a new joint in there, but it won't move as well. So, and you have to have good extensor mechanism. What that means is that the front thigh muscle should be in very good shape for you to have knee replacement. This is what artificial knee or total knee replacement looks like. So you can see femoral component, you can see tibial component. This is bone cement. This space is filled with what is called polyethylene component, ultra high density polyethylene component. And the plastic these days is so well developed that when you use the knee, it undergoes wear at a rate of 1/10 of 1 millimeter every year. 1/10 of 1 millimeter every year. So you can imagine that in about 15 to 20 years, it will have worn out maybe 1 to 2 millimeters. That's how the joints last for a long time. And this is the knee, kneecap. And here there is a plastic button. There's a little bit of cement. This is femoral component. This is tibial component. This is the plastic component right there. And this is bone cement. So this is what an X-ray looks like after knee replacement. So in summary, arthritis of the knee is a very common condition. Not curable, but it is treatable. Balanced diet, regular low impact exercises are part of treatment. Swimming, walking, exercise bike with low resistance. If you increase the resistance too much, your kneecap will really hurt a lot. Elastic braces are useful. You want to avoid metal hinges in the brace because they make your muscles too dependent. Only 1 tablet twice a day with food is a good basic medication as long as you don't have any stomach issues. Tylenol can be safely added. Topicals can be helpful like Voltaren gel or Tiger Balm or Vicks VapoRub. They also help. Salan Spa, Icy Hot, they help. Glucosamine and chondroitin, it's questionable use. If somebody asks me, should I take it? I said, try it for 2 to 3 months and see. Do not expect miracles. Don't spend too much money. They cost about $80 to $100 a month. No insurance company covers them. Most of the insurance companies don't cover them. So don't spend a lot of money on glucosamine and chondroitin if you are not getting better. Steroid injections do help to buy time. Your hemoglobin A1C should be ideally less than 7, but some doctors make exceptions, surgeons make exceptions and give it under 8. Gel injections help in mild cases. It is not much better than steroid. Need 3 to 5 shots and very expensive. Unloader braces, unload your pocket. Don't worry about getting an unloader brace. They cost like $500 to $600 and they try to align your leg artificially by putting a lot of pressure, trying to shift weight from one side of the joint to the other. And they are so uncomfortable that in my experience, most of the people give up using them after 2, 3 months. Arthroscopy can give you temporary relief, but you have to have very well selected case. Partial knee replacement, again, strict selection criteria. Revision to total knee is very difficult once partial replacement is done. The partial replacement is smaller procedure, but it leaves behind a big gap between the two bones, which you have to fill with new knee. So it's a little bit more difficult procedure. And total knee in selected cases is the gold standard. So once you reach a point where nothing is helping, and if you are advised by an orthopedic surgeon that, hey, knee replacement is a good procedure for you, you could comfortably consider that. Success rate is very high. Complication rate is less than 1/2 of a 1%. Most of the people get a lot of pain relief and they have much better quality of life. So that is how arthritis of the knee is treated. Thank you for your attention.